You guys, can you hear us today? Where are you from? Just throw it in the chat box. Personally, I'm in Iowa. Dr. Gichoya is in Georgia. Dr. Mathenge in Florida. I think she's borrowed there in Florida for a short while. Then she will be moving back to DC. That's where she does her stuff more. So anyway, because we don't have many people coming on board, I think it's good for us to start. We're gonna go ahead and I'm gonna give a chance Dr. Wanja Mathenge. First of all, thank you so much for coming in today. And you know, ophthalmology is not easy. And she's comes from Kenya, and I'm very proud of her. She's in ophthalmology. I don't want to introduce a lot or say a lot about her. I would like to give her a chance to go ahead and introduce herself. Then she can share the information that we really need ophthalmology. Welcome.
All right, thank you so much, Walter. Thank you, Judy Gichoya. Thank you so much, everyone, for being here this Saturday. I know it's a lot to do on a Saturday. It's a lot to us, but thank you so much. So just a little bit of introduction. I'm Wanja Mathenge. I am a PGY4 in ophthalmology. I go to Howard. So maybe just a little bit of background about me. I was born, raised in Kenya. I was telling these guys I grew up around Banana Hill area. And then I went to high school, Loreto Limuru. And then right after high school, decided to move to the States for my college. So I came to Miami for my undergraduate, Miami, Florida. It was a big city, massive city from upper, Limuru, then to Miami, which was a huge change. And then I was pre-med at Miami, then decided to sort of apply to about 10 medical schools. I ended up at Duke Medical School. And then while at Duke, decided to do a master's in between because I'm just interested in global health. So I did an MD, MSc, and then love ophthalmology so much. So I ended up deciding this is a specialty that I want to do. This is the person that I want to be for the rest of my life. So applied for ophthalmology, and now I'm in my final year of ophthalmology residency. I'm very happy to be just, to kind of see the light at the end of that tunnel. So I am going to talk today a little bit about some ophthalmology topics, USMLE topics. So I can go ahead and share my screen, right?
Yes.
Sure.
Okay, yeah, so let me share my screen. So can you guys see it?
Yes.
Okay. So it's been quite a while since I did step one. So I actually had to go back to first aid and look at all the different ophthalmology topics. And so based off of that, I'm going to give a talk on sort of some of the high yield topics. So this is what I will talk about today. One thing that I want to mention is if it's in red, it means that they also had it in red in the first aid book, and it's a little bit more high yield. So this is the eye. This is the anatomy of the eye. I don't know how it is in like med school in Kenya, but right here, no one teaches you ophthalmology. I think we have 2 to 3 hours of ophthalmology in all of medical school. So it's like one of those specialties where really no one knows what's going on. Everyone knows there's an eye, but what's going on with the eye, I don't know. But this is the anatomy of the eye. The main things to always remember here is the cornea, which is the front part of the eye. This is the clear part of the eye. Then you have your anterior chamber, then the iris right here. Then you have your lens, and then you have the retina, which is this yellow part right here. Then you have the vitreous, which is the gel that's inside. And then you have the optic nerve. So all of the nerves sort of center around the optic nerve, and this is what goes to the back of the brain. So this is really important. And then we do have the muscles that control the eye. So here we have the rectus medialis, or the medial rectus, and we'll talk a little bit about about some of these muscles. So the first thing that is pretty high yield for step one is conjunctivitis. And this, I think it's because this is also what ED doctors see and they should sort of be able to manage. So the main things to look for is a patient with red eye discharge. If the person tells you, oh, my eyelids have been sticking together or crusting, and it's usually worse when they wake up. If they have FPS or foreign body sensation, and then if it's less than 4 weeks, then that's acute conjunctivitis. If it's more than 4 weeks, then it's chronic. So you'll have a question about, so one of these things will show up in the question. Now, the next thing that you want to think about is this viral allergic or bacterial? So it's supposed to be bacterial conjunctivitis. So this is a picture of what viral conjunctivitis looks like. So it always starts with one eye, and then it involves the other eye in a few days. So there's always sort of a temporal relationship. So they just don't start together. They can, but the patients that we see, one eye starts before the other eye. The other thing that you will see with viral conjunctivitis is inferior palpebral follicles. So if you look at this eye right here, you can kind of see these small little like bumpy things, and those are the follicles. And then the patients will tend to have a tender palpable preauricular lymph node. So this is pretty much pathognomonic for viral conjunctivitis. Starts with an eye, goes to the other eye, they have some follicles, and then they'll have some tender lymph nodes. The other things that you may see are pinpoint subconj hemorrhages. And then you may also see membranes or pseudomembranes. So what this is a membrane. So you can kind of see you have your conjunctiva right here, and then you do have the pseudomembrane right here. So it's sort of a membrane on top of the conjunctiva. Then the other things, you don't really need to know these things, but usually I need my juniors to know what these are, like punctate keratopathy, anterior stromal infiltrates, and usually this will show up a week after the onset of the conjunctivitis. So the things that you may be asked is the etiology. So what is the etiology typically? Mostly it's gonna be adenovirus. So that's the answer. I don't think you guys need to know the subgroups and whatever, but typically we do, but the answer is always adenovirus. If the patient has pharyngeal conjunctival fever, then this is associated with pharyngitis and fever, and this is typically serotypes 3 and 7. If they have EKC, which is epidemic keratoconjunctivitis, this is caused by subgroup D and serotype 8, 19, and 37. But always remember adenovirus is what causes viral conjunctivitis. There is a specific type of viral conjunctivitis called acute hemorrhagic conjunctivitis. So these patients will have prominent subconj hemorrhages. So the whole eye will be super red. And typically this will last 1 to 2 weeks. Typically the patient will be from either a tropical region or in the US. We typically will see them in the southern United States. And this is not caused by adenovirus, it's caused by enterovirus, Coxsackie virus, or adenovirus serotype 11. So remember enterovirus, Coxsackie virus for acute hemorrhagic conjunctivitis. The main thing with management for viral conjunctivitis is don't really swab these patients unless it's sort of excessive discharge or it's something that they've had for more than 4 weeks. In terms of the treatment, it's self-limited. You do want to restrict work or school because it's very contagious. Frequent hand washing, you can give them artificial tears, cool compresses, and if they have severe itching, you can give them antihistamine drops. So this is the management of viral conjunctivitis. So you can kind of see no medication is really indicated for that. However, if they come in and they have the pseudomembranes, then you do have to remove the pseudomembrane. And then if they have that, then you do want to start a strong steroid, e.g. like prednisolone acetate 4 times a day. If they have subepithelial infiltrates, so these are what subepithelial infiltrates look like. I don't know if you guys can see them, but yeah, I remember when I was a med student, my residents would be like, oh yeah, can you see this? And I'm like, I don't know what I'm supposed to be seeing, but I don't see anything, but sure. So yeah, but now that, you know, after you've done residency for quite a bit, like you're seeing all these things. So these are what we call subepithelial infiltrates. So these are infiltrates in the stromal layer of the cornea. So anything that's more than the viral conjunctivitis, then you can add a steroid. So the other thing, guys, if you have any questions, just let me know. I guess I should check the chat frequently, see if there are any questions.
We're doing that for you, Wanja.
Huh?
We're doing that for you.
Okay.
Yeah, they're usually pretty interactive. So if you have questions, just put them in the Q&A. If you need something clarified, just say it and we'll stop Dr. Mathenge to answer them or clarify them. Okay? So you don't have to worry about watching the chat. Myself and
okay. Awesome, thank you. But yeah, definitely feel free to interrupt me if you have any questions. So the second type of conjunctivitis is allergic conjunctivitis. So the main things are the symptoms, itching, watery discharge, and a history of allergies. Then this will be bilateral. And then unlike viral conjunctivitis, there's no temporal relationship. It's going to be both eyes at the same time. So that kind of tells you, you know, when you have a question of someone comes in with 2 red eyes, then that sort of leads you down the path of allergic conjunctivitis. So in terms of the signs, so before I move on, if I remember, the questions are you have the symptoms, so the person presents, and then you have the signs, which is what you are seeing. So always remember there's sort of that relationship, so the presentation and then the signs. So the signs are chemosis, which is a boggy, sort of liquidy conjunctiva. They're going to have red and edematous eyelids, and then they're going to have conjunctival papillae. So this is really important because it's sort of like a code word for allergic. And so if you see this in your question stem, then it cannot be viral conjunctivitis. They will also have periocular hyperpigmentation, which is typically what you see in people with allergies, and they're not going to have any preauricular nodes. So this is not a viral conjunctivitis. So when you see papillae, think allergic or bacterial conjunctivitis. So pretty much the treatment is antihistamines or mast cell stabilizers, e.g. like loratadine, olopatadine, stuff like that. So it's, I don't know if you guys need to know this, but there's a difference between papillae and follicles. So papillae, this is what they look like right here. So you can kind of see they're bigger, and it tends to be fibrovascular molds with a central vascular tuft. So a papillae will be red and will have a blood vessel. On the other hand, a follicle will pretty much be a small translucent avascular mound of cells. So this is a follicle. It's not red, it's just like a raised, bumpy, translucent thing. This is a papillae, so there's always a small little blood vessel associated with it if you look closely. And that's allergic conjunctivitis. So now we go to the one that's pretty commonly asked, bacterial conjunctivitis. So these patients will come in with redness, they'll have foreign body sensation. And then unlike the others, they're going to have a purulent white-yellow discharge that's mild to moderate. And like allergic conjunctivitis, they're going to have papillae and they'll have chemosis. So this conjunctival issues, they all have like one small thing that makes it different from the other. And you can always pick it out from the question. The thing with bacterial conjunctivitis is you do need to differentiate between non-gonococcal and gonococcal bacterial conjunctivitis. So if a patient comes in and they don't have like any lymph nodes, any preauricular adenopathy, then that's non-gonococcal conjunctivitis. And the etiology for that will typically be Staph aureus, Staph epidermidis, H. influenza, strep pneumo, Varicella. So pretty much it's not gonna be like any Neisseria species. So, and then especially if the question has someone who has blepharitis, think non-gonococcal conjunctivitis. And the reason why you have to make the distinction is because there's a different way that you treat these two types of conjunctivitis. So if it's just gonococcal, then you're going to do, if it is gonococcal, you're going to do ceftriaxone, IM plus azithromycin, because you do have to cover for chlamydia. You also want to do like a topical fluoroquinolone, so you can do like moxifloxacin. The other thing is you want to do like saline irrigation, because these people will have so much matting, like their eyes will just be like having so much discharge. And definitely treat for possible chlamydia co-infection with azithromycin. So when someone comes in with this, you definitely want to ask about the partners and treat the partners for this patient. If it's non-gonococcal, then you want to do a topical antibiotic therapy. You don't need anything IM or IV or PO. Just give them a drop. You can do Polytrim or a fluoroquinolone like moxifloxacin. So that's the conjunctivitis. So there's one that's pretty specific called Vernal or atopic conjunctivitis. So this is will typically be seen in young boys. It's bilateral, so it affects both eyes. Tends to be seasonal, especially spring and the summer. And most of these patients will have some type of atopy or dermatitis or like asthma, something like that in their history. So these patients, how they present is very distinct. They're going to have papillae in the upper eyelid. So remember, we had the papillae down here for everyone else, the allergic conjunctivitis, the bacterial conjunctivitis. For patients with vernal or atopic conjunctivitis, it's going to be up here. They may have some papillae down here, but they're pretty big. So if you evert the eyelid, then you can sort of see the papillae. Remember, vernal means spring, I think. The other thing that some of these patients will have is a corneal shield ulcer. So their cornea is going to have an ulcer right here, and it's very well delineated. So you can kind of see, it looks like a shield, I guess. And it's a sterile gray-white infiltrate with an overlying epithelial defect. So this is painful. This is a painful ulcer. And the reason they get it is because their upper eyelid here, is sort of kind of rubbing over their eye. The other thing that they get are small little white dots around the cornea. So see this little moldy things here. So these are called corneotransverse dots, and they're pretty much degenerated eosinophils. I don't know that you guys need to know the whole corneal shield ulcer, corneotransverse dots thing, but this is very specific for atopic conjunctivitis, and typically will be seen in young boys. Another one that's important is herpes simplex virus conjunctivitis. So in terms of the symptoms, they will have your regular conjunctivitis. So conjunctivitis will be red eye, feeling like there's something in their eye, a foreign body sensation. Now, what will be special or specific about this will be the cornea itself will have what's called small epithelial dendritic lesions. And usually this will be seen, you stain them with fluorescein, and using blue light, you can kind of see them. Now that's not it for these patients. For us to be able to say, oh, this is kind of herpes simplex virus, they have to have this dermatomal skin rash along V1. So this is V1 right here. It's going to be unilateral, and it's going to spare the lower eyelid. So they'll have some vesicles right here, but they're not gonna have any vesicles in their lower eyelid. And it has to be dermatomal. The other thing is if it goes all the way to the nose, so if you have a rash that goes all the way to the nose, then that's highly predictive of ocular involvement. So if this lady had some lesions up here and the nose seems fine, then I'm not as concerned. But if I look at her and I'm seeing all this going on down here, then I'm thinking, oh, her cornea is involved. And this is called Hutchinson sign, and it means that the nasociliary branch of V1 is affected. So the nasociliary branch does travel intraocularly. So if it's affected, then the eye is also affected. So these patients can have edema both sides of the face, but the rash has to respect the midline. So in terms of working up herpes simplex viral conjunctivitis, you do have to kind of ask if they have any hearing changes, if they have any facial pain, any weakness or vertigo. And the reason you're doing that is you're looking for cranial nerve 7 involvement, because this will tell you that they have Ramsay-Hunt syndrome. So, you know, when I remember step 1, they had like all these random syndromes that you have to remember, and you never see them in practice. I mean, I've never seen this, but I've seen it so many times in questions, and I'm just like, okay, sure, I guess that helps me. But anyway, the other thing that you want to do for these patients is they need a dilated exam, because you want to look at the retina. So you always want to look at the retina if they have herpes simplex viral conjunctivitis. Why? Because you want to see, is my retina getting necrotic? So there's this thing called acute retinal necrosis in immunocompetent patients. If this patient is immunodeficient, then they have what's called progressive outer retinal necrosis. And the management of these two is very different from just simple herpes simplex virus conjunctivitis. So for the treatment, what you do is just acyclovir 800 q 5 times a day, or you can do valacyclovir 500 TID, I think 1,000 TID, and you do that for 7 to 10 days. If the eye is involved, definitely have them do cold compresses, lubrication, preservative-free artificial tear ophthalmic ointment. So what you guys just need to know is they do need some antiviral, acyclovir, valacyclovir, famciclovir. And then what sometimes happens is after the acute phase of the herpes simplex viral conjunctivitis, they can't come back in with what's called immune stromokeratitis. And for that, we typically start what's called a prednisolone taper. And then some of these patients will come back in with a neurotrophic keratitis. So what happens is the herpes simplex virus affects the corneal nerves. And so they do have this defects in their cornea. And pretty much what we do is we try to treat that as a corneal abrasion, so with ophthalmic ointment. So this is pretty much if they just have the conjunctivitis and the eye issues. Now, if they tend to have something deeper like a retinitis, a choroiditis, if the optic nerve is affected, or if they have one of the cranial nerves, like they're not moving their eye for whatever reason, then we have to escalate it and consult IAD or neurology. And then do not give prostaglandin. You don't need to know that if they have like increased IOP. So typically we see these patients every 1 to 7 days, every 3 to 6 months, especially if you've started steroids. So that's herpes simplex viral conjunctivitis. And then this varicella zoster virus also does cause a conjunctivitis. So these patients, though, they'll definitely have the facial rash that we know of, red eye, and the foreign body sensation. They will have your typical acute conjunctivitis. And remember, that's red eye, foreign body sensation, discharge, but they'll also have some vesicles or papules around their eyelid, the limbus. And then they have what's called pseudodendritic corneal epithelial lesions. So the reason why I put this in red is because if it's dendritic, pseudodendritic means that, you know, it's kind of like a corneal epithelial lesion, but not really. So the opposite of this is an actual dendritic corneal epithelial lesion, which we see with herpes simplex corneal disease. So anything that's pseudo is not herpes simplex. It's going to be varicella zoster virus. And typically for these patients, we just treat them with cold compresses, antibiotic ointment. And if they have any kind of stromokeratitis, then we do add a topical steroid, some type of cycloplegic drop, and then we also give them erythromycin ointment. And just like you know, herpes simplex conjunctivitis, they can present with other things in the eye, so as keratitis, an anterior uveitis, optic neuritis, retinitis, or ophthalmoplegia. Anytime they have some type of optic neuritis, we do consult neurology. So that's pretty much all you need to know about conjunctivitis. Really, it's probably more than you need to know, but just so that you know. The next thing that I'm going to talk about is refractive error. So refractive error is just needing glasses, pretty much. So this is divided into myopia. So this is nearsightedness. Patients who are myopic, the image is focused in front of the retina. So if this is the light, it focuses right here instead of on the retina, which is where we want it focused so they can see. So what we do for these patients is we correct with diverging lens so that now the light goes all the way to the retina and it's focused there. Hyperopia is farsightedness, and then the light is focused behind the retina. So if this is my retina, my light is getting focused right here. So pretty much I'm not seeing anything where I should be seeing something. So we pretty much give them converging lenses and then the light gets focused on the retina. So that's not all there is to refractive issues. Astigmatism is that there's a difference in the corneal curvature. So some people have round corneas, some of them are like football shaped. And depending on what kind of astigmatism you have, you can correct it with cylindrical lenses. I don't think I need you to know anything more than that. And then presbyopia is when you have decreasing ability of your lens to accommodate, and this happens with increasing age. And pretty much you correct with this with near glasses. And typically the question for this will be like an older person who suddenly can't read or something like that. So you just correct them with a near converging lens. So a plus 150, plus 250, plus 3, something like that to help them bring the image closer to themselves. The other thing that you may see is cataract. So this is a painless acquired opacification of the lens. So you've probably seen cataracts everywhere. So this is a very dense cataract right here. So you can kind of see it's like milky white. This is what's called the nucleus. So believe it or not, there are different layers to the lens. So this is the nucleus, and you can kind of see it's so milky that the nucleus has sort of settled down. And so the risk factors are age, smoking, diabetes, trauma, excessive sunlight, prolonged corticosteroid use. So the main thing with cataracts is it's going to be a progressive loss of vision. So if you have a question with someone who lost sight yesterday or 2 days ago, then it's not cataract, unless they had some sort of trauma, but then the trauma is actually what's causing the decreased vision. So the cataract is fairly painless and progressive. Now, if you have a young person with a cataract, you have to do more studies or you have to investigate further to figure out why do they have the cataract. So you always want to know about the trauma history because any trauma to the eye accelerates cataract formation. Anybody who's on steroid use for any kind of immunologic issue will tend to get cataracts earlier than people who are not on steroids. And then definitely smoking is a big risk factor. So there are different types of cataracts. But that's beyond the scope of USMLE 1. I think there are like 12 different types of cataracts. So I'm going to talk a little bit about glaucoma, which is pretty important. So there are three different types of glaucoma. So open angle glaucoma, closed angle glaucoma, and secondary glaucoma. So glaucoma is elevated intraocular pressure. So this here is a picture of the eye, the angle of the eye. So this is my cornea right here. This is my iris. So I've kind of taken a slice of my eye. So the aqueous humor, which is a fluid in the eye, is formed in the ciliary body. So this is where the aqueous humor is formed. It then flows under my iris, and then it's drained in what's called my angle right here. So there are two different outflow pathways. So we have the uveoscleral outflow pathway, and then we have the trabecular outflow pathway. So this is where we have the trabecular meshwork, which drains fluid. So this is going to be the majority of the outflow of the aqueous humor. Now, when you have glaucoma, something is wrong with your outflow pathway, right? So what's going to happen is fluid begins to build up. You have high pressure in the eye. It starts to compress back on your nerve all the way back, and then you develop glaucoma because the nerves are beginning to die because of the high pressure. So when we talk about open angle glaucoma, we mean that this angle is open. So something is going on in microscopically that's making the outflow not happen. When we have closed angle glaucoma, this angle is closed. So what's gonna happen is my iris right here has either come up here and blocked this angle. So that's going to cause pretty high increases in eye pressure because fluid is not going anywhere. Now remember, this fluid is constantly being formed. I think it's 2 to 3 microliters every day. So, I mean, every hour. So it's like constantly being formed. So there has to be a way for the fluid to come out. When we talk about secondary glaucomas, we're talking about other issues with the eye that cause glaucoma. So if it's inflammation, if the patient had trauma, and then that affects this angle right here, then that's a secondary glaucoma. So let's talk a little bit about primary open angle glaucoma. So it's primary because it wasn't caused by anything else. It's open angle because my angle is open. But what's happening is I have this patient with high pressure, they're sitting in front of me, and I have to try to figure out what's going on with them. So the symptoms will be visual field defects. Patients will have tunnel vision. Patients will have loss of central fixation. Now, when we talk about visual field defects in patients with glaucoma, most patients will not be aware that they have defects in the periphery. So what's gonna happen is, if you have someone who's never had their glaucoma treated, they'll come in with tunnel vision because their peripheral vision has all gone. So they're never aware of their visual field defects, but when we do visual fields on these patients, then you see this defect because no one is going through life looking through the side of their eyes. Everyone just looks straight ahead. So if you have issues with your periphery, then it's like you're not really aware of it. So in terms of the actual signs that we see, you have elevated intraocular pressure. So you measure their eye pressure through tonometry. So, I think I did see that at one of the USMLEs, which is measuring eye pressure, so tonometry. And unfortunately though, sometimes the IOP, the intraocular pressure, can be normal. The other thing that you want to do is gonioscopy. So gonioscopy gives you an idea of the patient's angle. So is my angle closed? Is it open? So anyone with high IOP, like when they come to our clinic, we always have to do gonioscopy because then that narrows it down to what is actually going on with this patient. The other thing that you want to do is look at the optic nerve. So this is a normal optic nerve right here. So these are my blood vessels. These are like the nerve, and they all go back to the optic nerve, which then goes to the brain. So this looks pretty normal. I have a healthy rim. I don't have a cup. So there's something called the cup. This is the cup to the disc, cup to disc ratio. So in glaucoma, that ratio is pretty high. So you can see this cup right here. So when I say cup, I mean the area where the vessels sort of congregate and sort of now go back. So that's called the cup. In patients who have glaucoma, they have what's called a high cup to disc ratio. So this could be anything like that. I'd say this is probably like a 0.7 to 0.8. And what it implies is death of the nerves. So many dead nerves around here. So if I did a visual field on this patient, I'm pretty sure they have some visual field defects. They may have central vision, but they do have like all these visual field defects. And then for all my images, I have the references at the end of the talk, just FYI. The risk factors for glaucoma, family history. So anyone who has a family member with glaucoma will have glaucoma. Patients of African descent, older age, patients with diabetes, patients with myopia, hypertension or hypotension. So any changes in blood tension do affect the nerves around about here, and that's because you do have all these blood vessels congregated in a small space. Now, secondary open angle glaucomas are caused by something else. So inflammation, patients who've had uveitis, exfoliative syndrome. So this is typically, you'll see this in Scandinavian patients who have pseudoexfoliation syndrome, steroid-induced, and not just topical steroids, but people who do take PO steroids for any kind of immunologic issue. Pigmentary glaucoma, which is when the pigment, the iris pigment, or any pigment in the eye gets deposited in the angle and blocks it. Angle recession, this is typically associated with trauma. So anyone who's had some kind of trauma to the eye, they may have that angle affected, or it's like either been cut. Any kind of traumatic glaucoma related to elevated episcleral pressure or intraocular tumor. So you can actually get a tumor in the eye, and that's going to raise your intraocular pressure. So the treatment is drops. So there are like 7 different classes of drops that you give to the patients. You don't need to know them. You can also do laser, and then ultimately you can do surgery if the IOP is not well controlled. So that's primary open angle glaucoma. The other one that you all need to know, anyone who works in a primary care or like an urgent care needs to know, is acute angle closure glaucoma. Now, the symptoms are pain, blurry vision, colored halos around lights, frontal headaches, nausea, and vomiting. So this is an acute presentation. The patients will have elevated IOP when they measure it. They'll have a closed angle in the involved eye. They'll have microcystic corneal edema. So if you look at this cornea right here, it's kind of hazy, it's not clear. So that's what's called microcystic corneal edema. They're going to have conjunctival injection. So this is not going to be a white eye, it's going to be a red eye. And then they have what's called a fixed mid-dilated pupil. So if you shine light on this iris, it's not going to constrict, it's still going to be mid-dilated. And it's mid-dilated because the dilation stops here. This is not a fully dilated eye, which would be fully dilated all the way. And the reason why it's mid-dilated is because the muscles that affect constriction and dilation are affected by the high pressures. So when this actually might show up, when you have this patient profile, the first thing that you want to do is gonioscopy. You want to be able to figure out what's going on with this patient's angle. The next thing you want to do is give them drops to lower the eye pressure. So in the ED, like we always tell the ED doctors, just give them everything, all the drops. Just give them all the drops at that time. Acute angle closure is like one of the ophthalmological emergencies. It's like we have 2 emergencies, this and retinal detachment. So this patient could lose their vision within 1 to 2 hours. So all topical antihypertensives, and then you can also give PO or IV acetazolamide or mannitol to this patient. So the definitive treatment for acute angle closure glaucoma is what's called a peripheral iridotomy. So you get laser and then you just make a hole right here. And what that deals is, it deals with the pupillary block. So if this is the patient's lens, what happens is the iris comes and like sits on it and presses on it, and so fluid can't go over the iris, and so you have to create a small little hole to allow fluid to go back. So in acute angle closure, so going back to this image, your iris presses on the lens right here. So there's blockage of flow right here, and that's why, you know, the ciliary body just keeps making all this fluid, and it all just builds up and pushes everything forward. So the definitive treatment is creating a hole right here through laser. So that's going to allow the fluid to go this way instead of this way. And when you create a hole, it breaks this apposition of the iris and the lens. So this is definitely a good one to know, just, you know, for yourselves and, you know, when you're out practicing too. The other thing that they do ask is uveitis. So there are different types of uveitis. Uveitis is inflammation of the uvea. The uvea consists of the iris, ciliary body, the choroid. So anterior uveitis is inflammation of the uvea that's anterior to the lens, so the iris right here. These patients will typically present with pain. They'll have redness. Very specifically, they will have photophobia. So anyone who tells you, oh, the light's making my eye hurt, they probably have uveitis. They'll have excessive tearing, and they will have decreased vision. So the signs are cell and flare in the anterior chamber. Typically, you need a slit lamp to be able to see that. I think they do have them in the ED, but most of these patients will be sent directly to ophthalmology. They will have ciliary flush, so this will be a red eye, and they'll have what's called keratotic precipitates. So keratotic is off the cornea, and so they'll have these precipitates right here. So this tells you this patient has inflammation of their, something in their uvea. So the etiology, typically this is idiopathic. What happens if someone comes in, oh, I'm having so much photophobia, I can't open my eye, it's been going on for the last 2 to 3 days. And then typically it has never happened before. So that is what we call idiopathic. But you always want to ask about other autoimmune conditions, because these typically tend to coexist. So if someone has rheumatoid arthritis, juvenile idiopathic arthritis, if they have, you know, lupus or other autoimmune issues, there's a higher probability that they can get anterior uveitis. If they come in a second time, then we do a dedicated workup to figure out why are they getting this uveitis. The first time we're like, okay, cool, I'm just gonna give you the steroids and you can go home. But if you come back again, I have to do a very dedicated workup. And so this is where you get your HLA-B27 labs, like DNA, like all these different things, to sort of figure out where is this coming from. The other thing is you can get postoperative iritis. So patients after cataract surgery or any kind of eye surgery will have photophobia, and you can sort of see that they'll have some iritis. So typically you don't really see this because anyone who has eye surgery sort of will get on a steroid, and that really sort of helps with the inflammation. And anything that's inflammatory gets treated with steroids. So anterior uveitis, photophobia, so don't forget the photophobia for that. Consensual photophobia means that when I shine light in the eye that's not affected, the affected eye is very painful, and that goes back to the pupillary light reflex. So the other thing that is on the step is age-related macular degeneration, so AMD. So there are 2 different types of AMD. So you have dry AMD, which is deposition of drusen in the macular region. So this is a picture of the back of the eye. Before your steps, just look at a few pictures of the eyes. I remember I used to be like, what is this red, orange thing, and what do all these things mean? I mean, I look at these things all day, every day now, so they all make sense. But I do remember as a med student, I was like, what is going on here? But so your blood vessels, this is the macular region. So this is where light goes straight to the macula when a patient is looking straight ahead. So what you're gonna have is all these small little yellow deposits, and they're called drusen. So what the patient will say is, oh, the straight lines look kind of wavy. Like when I look at my door, it's sort of kind of wavy. And so that kind of tells you that when the light hits, it's sort of getting something that's affecting the quality of the light. So this is dry AMD. Dry AMD in and of itself, you really can't do anything about it, but you can give them what's called the AREDS vitamins, AREDS vitamins, and I think it's a mix of like a bunch of vitamins like vitamin A, lutein, or I never remember what that is until I have to do an exam and actually look at what the AREDS vitamins are. But that's something that has been shown to halt the progression of dry AMD to wet AMD, which is the next stage of age-related macular degeneration. So remember, the management of dry AMD is just vitamins. For wet AMD, this is now dry AMD that has developed choroidal neovascularization, and then these patients now have hemorrhages. So if you look at this picture, this patient has a small little hemorrhage down here. So they probably started like this, and now they have this hemorrhage going on right here. So what we do is we take OCT images and we take a look at the macular region. And what these patients typically will need is anti-VEGF. They will need anti-VEGF. Sometimes it gets really crazy that they do need surgery. So anytime you have neovascularization or hemorrhage, think eye injections, so anti-VEGF. So VEGF, VEGF, is the vascular endothelial growth factor. So if I do not want neovascularization or I don't want hemorrhage, then I'm going to give an anti-VEGF injection to these patients. So, I remember my second year of residency, we had a dedicated retina clinic. And I mean, we were doing these injections every 30 minutes. I mean, we would just do injections. It was like an injection farm, just doing injections. So I did that rotation at the VA down in Florida. So Florida is where everyone in the US comes to, they just come here to retire. So we have so many old people. So everyone has some type of AMD, and it tends to be pretty much mostly Caucasian people who get AMD. You rarely find African Americans with AMD. So yeah, I do remember doing so many injections, and they really do work, because we see these patients 8 weeks later and they're like, oh wow, I can see. And I'm like, yay, awesome. So yeah, so that's AMD. So just make the distinction between dry AMD and wet AMD. Then the next one is diabetic retinopathy. So we're back to our little images. So this is always the optic nerve. So this tells you this is the optic nerve. So the way to know which eye it is, just FYI, is if the optic nerve is to the right, it's like a right eye, left eye. So diabetic retinopathy. What is diabetic retinopathy? When you have chronic hyperglycemia, this is going to cause inflammation in the blood vessels. This will typically show up especially in the small blood vessels of the eye, small blood vessels of the kidney. So you're gonna get diabetic nephropathy, neuropathy. So the small blood vessels tend to get affected. So if you have a patient with diabetic retinopathy, these patients almost always have nephropathy. Whenever I have a new patient coming in and I'm looking at their history, if they're getting dialysis, I am almost sure something is going on in their eye before I even see them. So diabetic retinopathy is divided into non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So this is NPDR. So this is what non-proliferative diabetic retinopathy looks like. When we talk about non-proliferative, we mean they have not proliferated new blood vessels. So it's like no blood vessels. But with proliferative, they do have new blood vessels forming. So this is what it looks like. So you can kind of see the small little vessels all over the place. But this one, they just have their native blood vessels. But what they do have is what's called hard exudates. So the blood vessels begin to leak fluid because they're compromised, because they have inflammation. And so what this manifests as is just hard exudate. So this is a chronic fluid that just settles in one small place. Now for this patient, you can kind of see they do have a small little hemorrhage right here. So for someone like this, I am going to look at their retina really well because I'm concerned that they may have PDR, meaning that they may have new blood vessels which are just like bleeding all over the place. So how do we treat NPDR? Just blood sugar control. There's really nothing that we can do for that in the eye. We just tell them you need to control your blood sugar. Your hemoglobin A1C has to be lower than 5 or something. For PDR, this is a bigger issue now because I have all these blood vessels in my eye that have been formed because the old blood vessels had so much inflammation that they're kind of dying off. And anytime you have dying off blood vessels, you release VEGF, vascular endothelial growth factor, which then leads to the formation of all these new blood vessels, which are not as competent as the older blood vessels. So for these patients, you have to do injections. So you have to do anti-VEGF injections. So I'm talking about Avastin, Lucentis, and stuff like that. You also want to do laser to this sort of retina. So you want to do like a PRP, pan-retinal photocoagulation. And ultimately, if they have bleeding, then you must do surgery to help their vision. So PDR is a much more serious eye condition. But what differentiates those two is the formation of new blood vessels. And NPDR typically progresses to PDR. So what's going to happen is if they don't control their blood sugar within a year, it transforms to PDR. However, with good blood sugar control, we do see patients who have NPDR for years. It just hangs there because they've controlled their blood sugar. So that's what you need to know for diabetic retinopathy. So just remember the new blood vessels in PDR and the hard exudates and some what's called dot blot heme in NPDR.
There's a question, would you say that there's a specific order of organ damage in diabetes, that maybe eye damage will happen before kidney damage?
I wouldn't say there's a specific order, but I would say that the smaller blood vessels tend to be affected earlier. So, for example, if we have a patient with type 1 diabetes, they have to be seen the year that they have been diagnosed because we know that they've probably had it. So when you look at their eye, they'll have some type of eye damage. So when we have a patient with type 2 diabetes who comes into our clinic for their first exam, so let's say they show up like a week ago, I know that they probably have had diabetes for maybe a year. It's just that this is when they're getting diagnosed. So they will have microvascular damage that I may not be able to see. So I have to see them the net for 6 months, make sure that is steady. But then I have to see them every year to make sure that they're not developing the diabetic retinopathy if they don't have it. So the smaller the blood vessels in that organ system, the faster the vasculitis or the blood vessel insult shows up. So if someone has diabetic retinopathy, they're probably going to be on dialysis in like 2 to 3 years or something like that. Now, if they don't have any retinopathy, then I'm always confident in saying that they probably haven't had diabetes for too long. But if they've had diabetes for like 5-10 years, they will probably have some type of retinopathy. So there may not be an order per se, but one predicts how long they've had it. So diabetic retinopathy will tell you they've had it for a long time, pretty much. So the other thing that we're going to talk about is central retinal artery occlusion, CRAO. So this is something that typically the ED doctors call about all the time, especially with our older patients. So the symptoms are unilateral, painless, acute loss of vision that happens over seconds. They may have a history of transient vision loss. So this is really important. It's painless, it's unilateral. It cannot be bilateral then, because then it's not CRAO. It has to be very acute, so it happens over seconds. So if it's more than like 5 minutes, then it's not a CRAO. If it's over 30 minutes, it's really not a CRAO. And then when you look at this patient, you're going to have superficial opacification or whitening of the retina. So remember, my retina typically looks pretty orange. When I have a CRAO, it looks more white. It's like a light orange. And what this tells me is there's retinal edema. So what that means is the blood vessels are not, it's not being perfused for whatever reason, and so it becomes very edematous. However, what's pathognomonic for CRAO is a cherry red spot, and you guys have probably heard about cherry red spots. So you're going to have this small little area in the macula that's still red. And the reason for that is because the macula is, the vascularity of the macula is different from the rest of the retina. So when you have your central retinal artery being occluded, the blood vessel that goes to the macula is not, and that's why you have the cherry red spot. When you have profound loss of vision, you have what's called a relative afferent pupillary defect. So these patients will have an RAPD. The differential for these patients is ophthalmic artery occlusion. So remember, your central retinal artery is a branch of the ophthalmic artery. So when if my ophthalmic artery is occluded, then even the vessel, the cilioretinal vessels that go to the macula, do not get any perfusion too. So the whole retina is gonna look white. So there's not gonna be any cherry red spot in ophthalmic artery occlusion. So if they show you a picture without a cherry red spot, it's not a CRAO, it's something else. If they show you a picture with a cherry red spot, it is a CRAO. But remember, there are other things that cause cherry red spots, Tay-Sachs, Niemann-Pick, but this will usually be both eyes, so not just one eye. I remember these things gave me so much trouble when I was studying for USMLE, because they all have like different enzymes or God knows what. I have, oh my God, it was so much trouble just studying for this different like Tay-Sachs diseases. But yeah, so CRAO will have a cherry red spot and profound loss of vision. So what causes CRAO? So the etiology will almost always be an embolus. So what kind of embolus? It's either cholesterol, calcium, or fibrin. So they may show you a picture of a retinal blood vessel with what's called a Hohenhost plaque, which is a cholesterol plaque. It's always going to be at a bifurcation point. So you're not gonna find it here, you're not going to find it here, it's not gonna be here, it's going to be at a bifurcation point. And what's important to know about that is they come from ulcerated atheromas of the carotid arteries. So always remember, it's the carotid arteries that are affected when you have a cholesterol plaque. Now, the other thing that it could be is a calcium emboli. So this is going to be white. It's not going to be yellow. It's going to be white. And this will typically rise from cardiac valve. So this is an important distinction. Cholesterol, carotids. Calcium emboli, cardiac. And then you can also have platelet fibrin embolas, which are dull white. And they typically also arise from atheromas in the carotid arteries. So what is the workup for a CRAO? So someone comes in, complete loss of vision, they have an RAPD, you dilate them. When you look with your indirect ophthalmoscope, you can kind of see the cherry red spot. So what we do is we send them to the ED ASAP for a stroke protocol, like a stroke workup. The other thing is you always want to get an immediate ESR CRP, and platelets, and this helps you to rule out giant cell arteritis, which is another important cause of profound vision loss and typically needs steroids to treat giant cell arteritis. So anytime, actually, if anyone comes in and they have complete vision loss, I always get an ESR and CRP just so that I can figure out what's going on. Now, because of the ulcerated atheromas of the carotid arteries, these patients with a CRAO will need carotid ultrasounds, and they're going to need an echo because of to look at the cardiac valves. So definitely want to do the labs. And then typically I always make sure I get into contact with their primary care doctor or neurology or just someone, because I can manage there really isn't anything you can do once the central retinal artery is occluded. That's vision loss, and they're going to have it for the rest of their lives. However, you can help them not to get a stroke or something that's far more devastating. So the other thing is there is anecdotal evidence that if someone has a CRAO, within 5 minutes, and you do what's called a ocular massage, where you're just like pressing their eye really hard to dislodge this plaque, it may help. It's anecdotal, like no one has studied it, but they always still try to do like an ocular massage if it happens at that time. But the thing is, these things always happen to people out in the community. And by the time you're seeing them, it's been like 4 hours, 5 hours. I mean, sometimes it's been like 3 days, and you really can't do anything. So that's
one question is, if you got a patient with acute vision loss, like in terms of an emergency, when you're not thinking that you don't have enough equipment, right? So you're in Kenya, the village, and someone has acute vision loss, and they call Daktari. In terms of thinking of the like the acute angle glaucoma versus the central retinal artery occlusion, sort of how would you sort of approach that case, understanding that you have limited resources?
Well, so if there are limited resources, there are certain things you can do at that time. So when someone has acute vision loss, the main thing that I would say, if I'm thinking CRA or central retinal artery occlusion, is I could tell them just do what's called an ocular massage. So press on your eye, because that can potentially dislodge the plaque that's affecting the eye. However, for acute angle closure glaucoma, that needs to be seen somehow, and they do need the drops to lower the pressure. So there really isn't anything they can do out in the community, and they have to be seen by some type of healthcare provider to give them the drops that lower the eye pressure. The other thing with acute vision loss, though, is it could be a retinal detachment. And if it's a retinal detachment, then they do need like specialized care, something to reattach the retina. So that would probably, I mean, you do need to be in a specialized clinic for things like a retinal detachment. However, for what will kill you, which is what we care about, so as an ophthalmologist, I don't want anyone to not have any vision. That's like your worst nightmare, but you don't want someone who's dead. If anyone has any kind of vision loss, then I'm thinking, is this an impending stroke? So they need to be seen ASAP so that you can do some type of workup, some type of imaging. And that's why we do like the carotid Dopplers, the echo, and all of this. So understanding that there are like limited resources in certain places, some of these things can be evaluated later, but something that has some type of artery, when I'm thinking of an artery occlusion, then I'm thinking, is there like an impending stroke? And so do they need to be seen ASAP? Because then that can lead to loss of life. But things like retinal detachments, and those need like specialized care. So the other thing is a CRVO, central retinal vein occlusion. So we talked about central retinal artery occlusion, central retinal vein occlusion. So this will be unilateral painless loss of vision. So it's pretty much the same as a retinal artery occlusion. The only difference is when you use your indirect ophthalmoscope and you're looking straight, this is what it looks like. It looks like a blood and thunder wonders. And so they'll have these dilated, tortuous retinal veins, hemorrhages all over the place, and what's called cotton wool spots. So this little white spot here, white spot here, white spot here. So compare this to a CRAO fundus. So the etiology is atherosclerosis of the adjacent central retinal artery. So remember, they travel together. So if my central retinal artery is affected, it will compress my central retinal vein. And so when my central retinal vein is compressed, what's going to happen is the blood can't flow back, from the eye back to the heart. And so it just becomes, they get clogged and super dilated and tortuous. So for these patients, what you always want to remember is hypertension. So hypertension is the most common systemic disease associated with CRVO. So anyone who has CRVO will almost always likely have hypertension. The other thing is they'll probably also likely have glaucoma. You also want to think about whether they have like a hypercoagulable state or vasculitis. So remember the hypertension and the glaucoma association with CRVO. So in terms of the management of a CRVO, the problem with any of these central retinal artery, central retinal vein occlusions is the vision loss is profound and it really doesn't come back. So what you're trying to do is manage the sequelae. So what happens with these patients is they get glaucoma, and so you have to manage the glaucoma. But I always tell patients who present with these things is that we're not going to get your vision back. It's not going to come back. But what we can do is make sure you don't have high pressures, make sure you don't have a painful eye, and then make sure that you don't have like a hypercoagulable state, make sure your hypertension is well controlled, make sure you don't have a vasculitis. So typically for this, I will send them either to rheumatology or like an internist to sort of see if there's anything wrong with their labs. But this is a picture that you will see for a CRVO. The other thing that was in the first aid book is retinitis pigmentosa. So with retinitis pigmentosa, these patients have decreased night vision, a loss of peripheral vision, and a decrease in the central vision that typically shows up later in life. But the big thing here is the decreased night vision. So someone comes in and they're like, I've been tripping over this and that at night. They probably have retinitis pigmentosa, especially if they're older. So the signs, which I don't know if you guys need to know, but it's a triad of pigment clumping. So you can kind of see pigment that's clumped all over the patient's retina. So this is called a wide field image of the retina. So they have like all these amazing imaging techniques in the States now where it's like you literally can see the whole eye. You don't even need to dilate this patient. You just take a picture of the eye and you can kind of see what's going on back there. So it's pretty awesome. So we have all these patients who are like, oh, I drove here. I don't think you can dilate my eyes. And so I'm like, okay, you're in the eye doctor's office. We won't dilate your eye, but I guess you can take a picture. So what it shows is the pigment clumping. And then you also have narrowing of the arterioles. So if you looked closely at this blood vessels, they're typically very narrow. And then you have optic disc pallor. So our ophthalmology exams, we have to know this triad off the top of our heads because then that tells you this patient has retinitis pigmentosa. Typically, they'll also have areas of depigmentation and atrophy of the RPE. What you guys need to know is the inheritance pattern of RP. So autosomal recessive is the most common. These patients will have diminished vision and nyctalopia, which is decreased night vision early in their lives. And then you also have an autosomal dominant inheritance pattern, which is less severe. So this will be an adult presenting with retinitis pigmentosa symptoms. So if you have a question where it's like, oh, it's like a 40-year-old or a 45-year-old, the inheritance of the RP is probably going to be autosomal dominant. If they have X-linked recessive, which is another type of inheritance pattern, these kids present when they're like 7 or it's very young. So this tends to be far more aggressive. So X-linked recessive, most aggressive, autosomal recessive, most common, starts pretty early in life. When I say early in life, I mean the teens, and then you have the autosomal dominant, which is less severe, develops in adulthood. I actually saw a guy who had retinitis pigmentosa. He was like, I think in his 60s. His vision was pretty good. I mean, but when I dilated his eyes and I looked to the back, I could see this whole pigment clumping, and it's very, very distinct. Unfortunately, he was complaining of night vision loss. So what that guy, when you're in your 60s, so I gave him like 15 years, and he was gonna be fine. It was just that he was probably not gonna be seeing well at night. His central vision would be fine though. So that's retinitis pigmentosa. The other thing that that I'm going to talk about is papilledema, which is optic disc swelling caused by increased intracranial pressure. So if you remember, my optic nerve, it looks pretty sharp, pretty sharp. So let's go back to the guy with the AMD. I can see my margins pretty well. But when I have papilledema, I can't see my margins. Like, it's just this white fluffy thing going on here. So what this is edema of the retina. So anytime you have whitening of the retina, that's edema of the retina. And typically papilledema is defined as optic disc swelling caused by increased intracranial pressure. So, but what do the patients say? They're like, oh, when I stand or when I lay down, I lose my vision, and it lasts a few seconds, but then it comes back. And then if they have like really high intracranial pressure, they're gonna have nausea and or vomiting. They'll also have like double vision. So anytime you see papilledema, you have to think of an intracranial tumor. And so that patients, they will typically need emergent MRIs or some type of emergent imaging. What we do here is we just send them straight to the ED if I see any kind of swollen optic disc. The other thing you want to think about is hydrocephalus, IIH, subdural or epidural hematomas, subarachnoid hemorrhages, AVMs, meningitis, encephalitis, and central venous sinus thrombosis. So with this other things, you're just not going to have papilledema, right? So if someone has meningitis, then they do have fevers. They do have like meningismus. If they have encephalitis, confusion. So they have all these other associated symptoms that they'll present with all other signs. If they have a subarachnoid hemorrhage, then they'll have like the worst headache of my life and all these other different types of signs. But if you are looking at someone who, and usually these patients are very casual. They're like, oh yeah, sometimes I lose my vision and then it comes back. And then you look in and you're seeing a swollen nerve. Typically, I'll just send them to the ED for an MRI. So now we will talk about pupillary control. So it's 11:07. So let me know if I'm going over my time.
I mean, I think we still have good attendance. I would say that we continue unless the people attending feel differently. And they usually put it on the chat, but I would say we can continue.
Okay. So let's talk about the pupillary pathway. This is also really important and always shows up in every single exam you'll do for the rest of your life. So this is the pons medulla midbrain, so your brain stem right here. So pupillary control begins in the brain stem, and then the signals go to the pretector area. So this is your pretector area right here. And then the signals go to the accessory oculomotor nucleus or the edgewestful nucleus. And then from the edgewestful nucleus, this signals travel down to the ciliary ganglion right here. This is your ciliary ganglion. And then with the short ciliary nerves will end up in your iris. So the other thing is the afferent pathway, which is the light that you shine onto the eye, travels with the optic pathway. So the pupillary tract and the optic tract travel together. So this is your optic, they travel together. And then they're gonna hit the LGN, the lateral geniculate nucleus. And then before they get to the LGN, which is where the optic tract neurons synapse, the pupillary pathway neurons will sort of separate, and then you'll also end up in the pretector area or the edgewestful nucleus. So this is the afferent pathway of the pupillary system, and then this is the efferent pathway from the edgewestful nucleus all the way back to the eye. So understanding that pathway is pretty important because then it allows you to sort of understand certain things that you see with the eye. So that's the parasympathetic pathway. So this is the pathway that constricts the eye. And then we have the sympathetic pathway, the pathway that dilates your eye. The signals begin in the hypothalamus and then travel with what's called a first order neuron and synapse between C8 and T2 in the spinal cord. So that's your first order neuron. And then it synapses right here, and then that begins your second order neuron. And this is gonna go all the way up to the superior cervical ganglion, which is right by your neck. Then you have your third order neuron, which is what ends up in the dilator muscles of the iris. This is very important because you can localize what is going on if you know what signs show up. If I have an issue with my first order neuron, my second order neuron, my third order neuron. So all of this is neuro-ophthalmology, which tends to be very exciting, but can be very frustrating, especially when you have a patient in front of you and you're trying to figure out what's going on with this person. So let's talk about Horner syndrome. Horner syndrome presents with three things: PAM, ptosis, anhidrosis, and meiosis. So you're gonna have a patient with a droopy eyelid. They're going to have, it's gonna be pinpoint, and they're probably not gonna be like sweating in that side of the face. So the anhidrosis is mostly like easier to see in, I think, Caucasian people, because typically I can't tell if someone's like having anhidrosis when I'm like sweating or whatever. So it's pretty much easier, especially when people who you can tell when they're pale or like flushed or stuff like that. So if the etiology of Horner syndrome, if it's a first order neuron, you're thinking it's either a stroke, tumor, or MS. Second order neuron, and so the way that you determine which neuron it is you can give some eye drops in clinic. So aproclonidine is one of them, but I don't think they need you guys to know how to differentiate which neuron really it is. But what's going to happen though is, depending on which neuron, you'll have other signs. So they're just not going to present with ptosis, meiosis, and anhidrosis. So if it's first order, they're going to have a stroke, they're going to have a tumor, MS, they're going to have other signs happening. And so that helps you to zone in on MS or tumor or stroke. If it's second order, then it's either a pancreas tumor, so a tumor up in the upper lung region, some type of aortic aneurysm. If it's a child, consider neuroblastoma. And this is really interesting because we actually had a child who presented like this in our pediatrics clinic, had ptosis and just wasn't making any sense. And then once we did the imaging, they actually did have a neuroblastoma. And then if it's third order, consider cluster headaches, migraines. But what you want to think about that's life-threatening is an internal carotid artery dissection. So that patient needs to go to they need to be evaluated ASAP. So what they'll have though is pain in the neck region. So they just don't have a Horner syndrome, they have a Horner syndrome with pain. So the workup for Horner syndrome tends to be just imaging typically. Then I'm going to talk about cranial nerve palsies, which are pretty high yield. Cranial nerve 3 palsy. So what the patient says, the symptoms are binocular diplopia and ptosis. What you see, the signs are there are limitations of ocular movements in all fields. So they can't move their eye up, they can't move their eye down, they can't move their eye inwards, so adduction. The only thing they can do is abduction, abduction. They can move the eye temporarily. And that's because the lateral rectus, which controls lateral motion or abduction, is innervated by cranial nerve 6. So when you have a cranial nerve 3 palsy, the next step is to try to figure out, is this pupil involving or is this pupil sparing? If it's pupil involving, it means that I'm shining light into this pupil and it's very poorly reactive. And so what these patients need is urgent imaging to rule out a posterior communicating artery aneurysm. So if it's pupil sparing, so they have normal pupillary responses, then I can breathe easy because it's probably ischemic microvascular disease. So that's cranial nerve 3 palsy. So if you look at this patient right here, they have a little bit of ptosis in the left eye, right? And I know it's ptosis because it's kind of covering the cornea. Because if I look at this other cornea, I can see the superior border right here. When you tell this patient to look up, they're looking up with their right eye. Their left eye is still same position. When you tell them to look down, they can look down with the right eye, but the left eye is not really moving. Then I tell them to look to the left, and so their left eye can move to the left, right? So cranial nerve 6 is intact. However, when I tell them to look to the other side, the right side, this eye cannot move. So my medial rectus is not working. So medial rectus is innervated by cranial nerve 3. So for someone like this, I have to look at their pupils very, very carefully to make sure that it's either pupil sparing or pupil involving, because that really changes how you manage everything. Cranial nerve 4 palsy, which is superior oblique palsy. This is another one that they ask. The patient will typically complain of binocular vertical or oblique diplopia. But remember, these patients don't say, oh, I have vertical diplopia or I have oblique diplopia. They're just gonna say, oh, everything looks double. They're gonna have difficulty reading, and then they'll have a sensation that objects appear tilted. So this is important for cranial nerve 4 because the superior oblique is involved with torsion, extorsion, intorsion. So when things appear tilted, then you can pretty much be sure that something is going on with my superior oblique. When you tell them to look down and in, so down and in, they can't be able to do that. So the superior oblique, here the right superior oblique controls downwards motion and inwards motion, so they're not able to do that. So that's a superior oblique palsy. Cranial nerve 6 palsy, which is the lateral rectus. So this is my lateral rectus here. You're going to have deficient eye movements to laterally. So these patients pretty much cannot move their eye that way or that way. And this one tends to be an easy one to figure out or to see. What causes this palsy typically is ischemic microvascular disease. However, for cranial nerve 3, you definitely have to consider the posterior communicating aneurysm. So this needs a more involved thought process. The other thing that I'm going to talk about is visual field defect. So we're coming towards the end of the talk, so last couple of slides. So this is important for you guys to know. So if I have a defect with my left optic nerve, then you're going to see a complete loss of the visual field. If it's the chiasm, then you have bitemporal hemianopia. They always ask about this one. If it's the right optic tract, then I am going to have left homonymous hemianopia. It can be congruous or it can be incongruous. Typically, it's going to be incongruous. And things are congruous the farther back you go in the visual pathway. Then you have the lateral geniculate nucleus, and what this shows up as is sectora nucleus. So small little section right here, small little section right here. Now this is the lateral choroidal artery or the anterior choroidal artery. Depending on which one is affected, you may have a sectora nuclei right here or a sectora nuclei right here. But all you guys need to know is it's a small little sector. So it's not like a hemisphere or like a quarter, which is a quadrantal nucleus. So that's the LGN. It gives you sectora nucleus. Left temporal lobe. You'll have what's called a pie in the sky defect. So you have this quarter little circle in the upper visual field. And then if it's the parietal lobe, then it's sort of a pie on the floor. So right homonymous defect if it's the left parietal lobe. And then once we go to the occipital lobe right here, then we introduce the concept of macular sparing. So this is your macula right here. It's innervated by different blood vessels. So most of the time it's going to be macular sparing. So this whole field defecting, it's important to just take a look at it, maybe like a week or two before, because I now know this just because once you understand the anatomy, the physio, everything, then you don't really have to like cram them. But I remember as a med student, like half of these things were just so new. And so I would pretty much sometimes just cram them. But it's always good to kind of understand it, but I do understand you may not have time to do all that. Yeah, so these are my references, and thank you so much. Does anyone have any questions?
Thank you, Dr.
I'm right at 11:30.
At the end, could you please elaborate drugs for glaucoma?
Oh yeah, sure. So glaucoma management, let me talk about how we go down the management. So the first thing that you want to always give the patients is a prostaglandin analog. So typically this is a nightly drug. So we either give latanoprost, and it drops the pressure by 20%. So new patients comes in, they have high eye pressure, I'll put them on latanoprost. If they come back in 4 weeks and the IOP is not well controlled, then I'll add more drops. So you can do the beta blockers, so timolol, or you can do the CAI, carbonic anhydride inhibitors, so like brinzolamide or dorzolamide. So it's a stepwise process: prostaglandin analogs, beta blockers, carbonic anhydrase inhibitors, and then you can also go down to brimonidine, which is an alpha-2 agonist. And so pretty much what happens is if the drops are not working, then we can escalate to acetazolamide, which is Diamox, which is a pill. But typically we do the drops first, and then we do the Diamox. Okay.
Awesome. I mean, I think this was such a fantastic lecture. Actually, those things used to scare me. I don't know, maybe it's just you made it very easy to like even read, like just look through and be like, oh, okay, I can see that. I can see those images. So thank you so much. I think in future we'll have sort of like a more informal session where people ask sort of like, journeys. There are lots of people asking for notes, and I said that we usually will upload this to the online so you can just rewatch, because I think there's just so much that was explained and needed to be unpacked, you know?
Yeah, it's a lot of information, especially when it's not like something you see every day. It's a lot of information.
Yeah. So could we say thank you to Dr. Mathenge in our usual way, so as Walter wraps up and tells us who's coming next week?
Yep. I was promising them, you know, the other day I was presenting neurology. I was promising them, you know, I don't know this stuff, but I know one person who might help. And you came in handy and you did it today for us.
Absolutely, yeah.
Most of the stuff we talked about, they are super, super high yield.
Yeah.
I did want to emphasize like cherry red spots. the way you mentioned them with name and peak and Tay search. You guys, you need to remember those for the exams. That's amazing. So we look forward to engaging you again, Dr. Mathenge. Thank you
You're
so
welcome.
much.
Thank you so
And
much for
I
having
guess,
me.
Oh, now
sure,
this is when
sure.
you can look at the chat, Dr. Mathenge. You'll see many thank yous coming in there. We do it in our webinar format so that it's too crazy to kind of control like background noise, but definitely lots of asantes coming in. So thank you so much.
Sure.
Well,
So next week we'll have Dr. Judy Gichoya helping us with somebody from San Francisco, California. So we'll have neuropathology. I will not be there personally. I think the subsequent weeks I'll be a little bit busy, but I have a team which really is always there for us. So guys, look forward for that coming time, and let's do this again. Thank you so much, Dr. Gichoya. I saw Dr. Newsom came in a little bit.
Yeah.
Yep.
She says hi to everyone, and she's actually recruited more people. So
Awesome. That's
we have some
really
MSK
good.
and we have a few more things. Yeah.
That's really good. So we're gonna have like an open university, I guess, dealing with medicine here. Thank you so much. And unless Dr. Wanja, you have something you can tell the people in Kenya, just something to make them do the exam, and what, like, any motivation statement you can give them before we close.
Sure. So anyone who's planning on doing the exam anytime soon or whatever time you're doing it, all I'd tell you guys is repetition. That's the foundation of any kind of knowledge. When you see something one time, it's okay. Second time, by the third time, things stick to your head. So repeat your UWorld. I think I always tell people you can't just do it once. You have to do it twice. And what that means is that that's a lot of prior planning. So that means that you have to see the future exam date and then plan to do your UWorld 2 times. The other thing is don't do the exam if you're not scoring where you need to be scoring for whatever specialty, because the NBME tests really do predict what you're gonna score. So, but just like everything else, persistence, be persistent, be just resilient, just keep doing it. You will get somewhere with the effort. So if you have any questions, let me know. We've been through this journey. It never ends. I'm preparing for another exam, so never ends.
Thank you so much. So unless Dr. Judy Gichoya, you have something to say.
No, that we usually reserve that for Dr. Newsom, who jumped off.
Okay.
Okay.
Okay. Thank you guys. Have a nice weekend. Bye.
Bye.